you. Thank you, Matt. Thank you for the invitation to speak at the Corporate Forum, and thank you everyone for being here. I'm so happy to see people in this room, considering that there's like 9 other corporate forums going on, and you chose the only corporate forum that really matters, which is Maxius. And I want to take a moment to acknowledge my 3 dear friends and colleagues, Fadi, Brad, and Matt, who spoke before me, delivering some outstanding presentations with amazing content, documentation, really set the stage nicely for me to talk about the peri-implantitis conundrum. So what is a conundrum? Well, by definition, a conundrum is a confusing or difficult problem to solve. And as periodontists every day in private practice, successful, or rather achieving successful and predictable outcomes in treating peri-implantitis is indeed a very deep clinical conundrum. And so it is incumbent upon us as professionals to seek out strategies, tactics, biomaterials to aid us in shifting that balance from one where we're kind of 50-50, maybe unpredictable, to one where we're going to be more successful and more predictable. And my talk today is going to really focus on how I incorporate the use of Amnion-Chorion membranes in my surgical treatment of peri-implantitis, and in the process of doing so, explain to you why Amnion-Chorion membranes, in specific BioExclude, is a game changer and will continue to be a game changer for me, and hopefully after this lecture, you'll also give it a try, if not doing so already. This is a corporate forum. I'm a KOL consultant for Maxius. And that being said, I'll be speaking today about BioExclude, as I mentioned. And I've been using BioExclude in my office for the better part of a decade. And I wouldn't stand here in front of you speaking to you about this lovely material if I didn't feel that I had the authenticity and integrity to do so and talk to you honestly about my experiences. That's very, very important to me, regardless of the fact that this is a corporate forum. My presentation will not be showing anything investigational or off-label, and every case I show you, the good, maybe the not so good, is my own case, and there's been no photographic manipulation to misrepresent the final outcomes. And last but not least, everything that I share with you today is evidence-based and also a bit my interpretation of the literature as well. So that being said, there's really great honor and pleasure for me to have the opportunity to present on a topic which is near and dear to my heart in my hometown. And I want to officially welcome you all to my amazing city, and I hope that in the next few days, aside from the educational offerings, you'll be able to take in a great dinner at one of our lovely restaurants in the downtown area, maybe catch a show. We're in the theater district, maybe even go to the Leafs game tomorrow night. And if you're lucky enough, you might even catch a glimpse of our city's unofficial mascot, Drake. But the most important thing in Toronto right now, at this moment, besides the AAP and the Maxius Corporate Forum, is the Toronto Blue Jays. Big game tonight in Seattle. Go Jays, go. I work in a town called Aurora. Not Aurora, Colorado, Matt, because I know that you're nearby there, but Aurora, Ontario, which is about 20 miles north of the Greater Toronto Area. What's good about Aurora is that, what's great about Aurora is that it's this little small town nestled amongst a whole bunch of townships and villages that we draw our referrals from, I'd say probably about 30-mile radius from all directions. It's just close enough to the city of Toronto that you can enjoy the city, but just far enough away that you can avoid the riffraff of being in the big city as well. And I'm extremely blessed to work with this incredible group of individuals, our support staff, who I can't thank enough for what they do for our patients, what they do for me, how they assist me in allowing me to document my cases the way that I do. And I'm sure that this group of periodontists that I work with, there's 6 of us now, that also feel the same way. For those of you that work in a group practice, you'll be able to attest to the fact that it's nice to have other people that have strengths and interests that maybe are not the same as yours, and you can leverage each other's experiences for ultimately the betterment of our patients. Because as our as the mantra that I'm trying to live by these days from one of my mentors that's in this room, Dr. Michael Sonic, we're treating people, not patients. I'm really blessed to have these guys as my teammates. These two guys, they're here in the front row. They're my classmates in dental school. We did hospital residency together, and now we did our perio training together at University of Toronto, and now we work together, and they're here at my lecture. We just cannot escape each other. And I got to mention Dr. Amy Young as well. She's here as well. And we all need to have a good support system, and we're extremely blessed going to University of Toronto that the year behind us and our year are extremely close, and we've maintained this really good bond over these last 20 so years, and we call ourselves affectionately the Perio Pals. And I just want the Perio Pals to stand up and let's acknowledge what you guys mean to me in my life, and I am what I am a lot because of you guys. So yeah, this is phenomenal. I'm really happy that you're here. So what are we going to talk about today? Well, we're going to talk about peri-implantitis, but specifically we'll do an overview of peri-implant diseases. We'll talk about the diagnostic features of peri-implantitis. We'll talk in detail about the surgical treatment of peri-implantitis, where I'll show you numerous cases that I've seen in private practice, with the bend of how I incorporate BioExclude and how you can incorporate BioExclude as part of your surgical peri-implantitis treatment power play. Now, the theme of this afternoon has been power play. It's a hockey term. For those of you who may not be as familiar with ice hockey or the rules, a power play is a situation when one team has a one person or more advantage over the other team because the other team has committed some type of infraction or penalty. So you can imagine when you look at this picture on the left that one team has 5 players and the other team has 4 players. And just having that one extra skater on the ice can really change things. It can actually change the game and shift the momentum in favor of the team with the power play. Secondly, it can also help to expose the vulnerabilities on the defensive side, perhaps leading to more goals being scored. And then this can also lead to having a better long-term strategy, because if they try something on the power play that works, perhaps they'll try it again in subsequent games when they have more power plays. And I like this analogy for treating peri-implantitis because we want to have a biomaterial or technique that can shift the momentum of our success and predictability. And we know from a defensive standpoint that one of our biggest areas of weakness is our ability to effectively decontaminate the implant surface. And if we can get 1 and 2 right, then we can have a long-term strategy for shifting that balance in favor of success and predictability when we're treating peri-implantitis. Unlike GBRs or socket preservations where you're dealing in typically non-infected areas, treating peri-implantitis is that much less predictable because it's a much more hostile environment. So if I was to type in peri-implantitis in PubMed as a key word, just as a crude way of searching for how important a topic is, I can see that in the last 14 years, there's been over 5,100 articles that feature the word peri-implantitis. Now again, this is a very crude way of looking at the literature, but it tips us off to how important a particular problem is, okay? Because in the 30 years preceding this, there was maybe 500 articles at best. Now there's 5,000. And this graph I made about a week ago when I was preparing for this lecture, putting the final touches on it. So I bet you if you typed in peri-implantitis today, maybe the number would be like 52 or 5,300. Although the definitions of peri-implantitis in the past were largely dependent on our diagnostic thresholds, we can agree that typically 1 out of every 8 implants, or 12.5%, would be affected by peri-implantitis at some point in their lifespan. And from a patient perspective, and Dr. Fine alluded to this as well, 1 out of every 5, or 20% of patients, is affected by peri-implantitis. I think that this is likely an underestimation because, again, a lot of these studies that look at the incidence and prevalence were very heterogeneous. And case definitions sometimes could be very narrow, sometimes they could be too broad, and so we don't really know what the real number is, but I do suspect that it's greater than this. And again, if anything in our practices is 20% prevalent, that's a huge problem. And we have to know how to treat it in a way that we can decrease it. Will we ever eradicate peri-implantitis? Probably not, so long as implants are in the mouth, and the mouth is the dirtiest environment in the human body, but we can do what we can to get that number down so that we don't have to treat it as frequently. Luckily for us, in 2017, we had this World Workshop consensus meeting in Chicago, and for the first time, our diagnostic classifications included a category for peri-implant diseases and conditions. Because in the 20 years from the last classification, which was from 1999, implants have taken off in private practice. So the working group identified 4 different categories of diagnosis: peri-implant health, peri-implant mucositis, peri-implantitis, peri-implant soft and hard tissue deficiencies. Now, again, in the interest of time, we can't focus on all of these, so we're going to focus exclusively on peri-implantitis. So if we look at the definition of peri-implantitis, strictly taken from the consensus report, it is a pathological, biofilm-associated inflammatory condition characterized by inflammation of the peri-implant connective tissue accompanied by bone loss, crestal bone loss, which progresses in a nonlinear, somewhat accelerated fashion. Visually, we see the signs of inflammation. We see erythema, we see edema. When we probe, we see deeper probing depths compared to baseline. That's one thing that you all should be doing, or our restorative doc should be doing, is taking baseline probing depth measurements prior to prosthesis delivery, so we have something to compare to, because a probing depth or a pocket depth around a natural tooth is very different than what we see around a dental implant. Around a dental implant, it's essentially a man-made construct, okay? Because in the maxillary anterior, for example, it's normal to have a 6 or even 7 millimeter probing depth around an implant, and so long as that is healthy, it's not disease. The asterisks here represent bleeding on probing, and you can see this separation. Radiographically, we want to see, well, we don't want to see, but in order to diagnose peri-implantitis, we have to see bone loss to a point beyond that which we expect physiologically. So it's pretty clear that when these implants are placed, I'm assuming that the bone level was somewhere where the red line is. And over 7 or 8 years in function, that bone has been lost. And so, again, to recap, we want to see inflammation, erythema, edema. We want to see bleeding on probing and separation, and we want to see a relative increase in pocket depth. Now, as periodontists, a lot of us don't have access to historical data. And in the absence of historical data, if we see 6 millimeters or greater of pocket depth, that's a red flag towards our diagnosis of peri-implantitis. As far as bone loss is concerned, again, in the absence of historical data, if we see 3 millimeters or greater bone loss beyond where we typically expect the bone to be with all these other features, then it's safe to say that we can make a diagnosis of peri-implantitis. How do we treat peri-implantitis? Well, first we have to diagnose it, and then we have to remove all the local factors and systemic factors, take care of all that stuff. And then we put the patient through non-surgical therapy. And this is one thing I'll say, always non-surgical therapy first. Even if you know that a case is going to be surgical, always non-surgical therapy first. And in our practice, it's not uncommon for us to put the patient through sometimes 1, 2, 3 rounds of non-surgical therapy before we progress to surgical therapy. And so oftentimes, treatment of peri-implantitis involves a combination of surgical and non-surgical. Okay? Why do the non-surgical if you know that you're going to go surgical? Because the non-surgical therapy alone can improve the quality of the tissue, reduce the inflammation, reduce the bleeding, get the tissues in a good state such that they can handle the rigors of the surgical procedure. Now, as far as what non-surgical therapy to use, I'm not going to talk much on that. Suffice to say that the consensus appears to be that there's really no therapy that's more effective than our conventional non-surgical debridement. Occasionally, we can add a localized delivery of antibiotic to the mix to get that extra bit of inflammation reduction. But really, we don't have to be all fancy here with lasers and LAPIP and all this type of stuff, with all due respect to those people that use it. So, in the surgical realm, we've got non-augmentive therapy and we've got augmentive or combined therapy. Non-augmentive therapy is typically done for situations where there's supracrestal bone loss, horizontal bone loss, and success rates, just about greater than 50% over 2 to 5 years. You can essentially flip a coin, but 3 to 14% of the implants are lost within 1 to 5 years. Okay, so you're buying a little bit of time, but it doesn't look like you're buying that much time. With augmentive therapy, which is typically used for regenerating bone around intrabony defects, we see similar success over 5 to 7 years, and 3 to 25% of the implants are lost within 1 to 5 years. That's a pretty wide range, okay? 3 to 25%. Who do you believe? It depends on who you read, I guess. But what this says to me is that there's a huge opportunity for us as periodontists to really think about how we want to treat this particular condition. And I think if we're able to leverage biology, leverage biomaterials, and really use the best of all worlds that are available to us, then maybe we can, again, shift the success to higher than 50%. Because, again, what's the incentive for the patient to want to save this implant if maybe a quarter of them might be lost after 1 to 5 years? A recent AAP consensus conference on the management of peri-implantitis. And again, I find with a lot of these consensus meetings and systematic reviews and meta-analyses in dentistry, they essentially tell you what you already know. Okay? Nothing really changes from year to year. And this recent one showed that reconstructive therapy is good for reducing pocket depths, mucosal recessions, as well as increasing marginal bone levels. But there's really no difference between resective and regenerative therapy when it comes to bleeding on probing or suppuration reduction, which is fine because we know that whether we have a horizontal defect or a vertical defect, either way that we treat it will result in bleeding on probing and suppuration reduction. And then they conclude in this consensus that reconstructive therapy may provide a suitable approach for managing peri-implantitis intrabony defects. And then the follow-up article concluded that the sky was blue. Okay? I'm just saying. In private practice, we see these type of defects every single day. Different morphologies, different topographies, different implant systems, different surfaces. And it's not always obvious which ones can be saved and which ones can be retained. You'd be surprised that the ones that you think need to come out can actually be saved. And so the question that we get asked, another clinical conundrum, is to explant or not to explant? To rescue or not to rescue? And earlier on in my dealings with peri-implant diseases, I had a very straightforward way of making my decision. If it was my own implant, I would try and save it. If it was someone else's implant, I'd take it out. But ever since then, I've decided not to discriminate against implants or the surgeons that place them and treat all implants as equal in the fraternity of dental implants. And what I really go by now is how the intrabony defect actually is. Okay, that's the first place that I start. And this is a great paper by Alberto Monge in Spain, where they talked about the morphology severity of peri-implantitis bone defects, and that 3 categories: class 1, class 2, and class 3. Class 1A is represented by a buccal dehiscence. 1B is when you have the implant within the envelope of bone, but with 2 to 3 bony walls present. So there's still a well-contained defect. And a class 1C is a circumferential defect, much like the ones that I think Dr. Brad Ross showed in his presentation early on. A class 2 is a supracrestal or horizontal defect, where we're not really trying to do any vertical regeneration in this case. And a class 3 is essentially a combination of a class 1 and a class 2. There's a horizontal component and a vertical component. And you can imagine as you go down the spectrum from class 1 to class 3, the predictability of treating these defects probably gets lesser and lesser. You know, the magic really happens, I think, in the 1B and 1C, where you've got still containment of the wound, and the implant is within the envelope of bone. With a class 3, they're treatable, but you're only limited by the extent of your horizontal bone level, okay? Then furthermore, there's a grade that we assign to this, which depends on the amount of the implant length which has been impacted by the bone loss. A slight grade is when less than a quarter of the implant length is affected. Moderate grade, or M, is when half to a quarter of the length is affected. And advanced grade is when more than 50% of the implant length is affected. So this is the best place to start. And much like when we're probing around natural teeth to get a mental map of what a bony defect could look like, we can do this before we do any surgery. Sometimes it requires anesthetizing the patient, taking our probe, and carefully walking it through the peri-implant sulcus, not just to get probing depths, but to get a picture in your mind of what that bony topography looks like. So let's start with our first case. So this is Lloyd. And Lloyd, when he was referred to me by his general dentist, a 68-year-old gentleman in good health, dairy farmer, and just a salt-of-the-earth kind of guy. And you can tell from the radiograph that he's got mesial and distal angular bone loss of the 2-6, or the number 14. See, I learned, implant. Now, unfortunately, I don't have a clinical photo preoperatively. And I want you to assume, and I want you to know, not just assume, that for every case that I show you, the patients have been put through non-surgical therapy first, okay? So after putting him through non-surgical therapy a couple of times with localized delivery of antibiotics, the situation just wasn't progressing. The implant was well placed. It was placed by an oral surgeon about 8 years prior, and it was a cemented crown. And the 6 months leading up to his referral, he'd had some flare-ups which were treated with antibiotics, which would help temporarily until the flare-ups would start again. So after he had non-surgical therapy in my office, and with very limited improvement, we said, let's open things up. At that point, I didn't even really talk to him about the possibility of explanting, because I saw that we had a fairly well-contained radiographic defect. I thought, hey, you know what? Let's see if we can save this. This is what I saw when I raised my flap. So now I'm rethinking my strategy here, because I see almost all of the implant surface affected by the buccal dehiscence. But the implant was well integrated, and we had 3 bony walls around the implant. And the access was really good. So in addition to your intrabony defect configuration, the other thing you have to evaluate is how accessible this implant is for implant surface decontamination, okay? So I classified this as a class 1B because it's got 2 to 3 walls remaining. Grade A, advanced peri-implant defect. So this is probably something that I would try and save more often than I wouldn't. Now, I know there's some people in the audience that may, shun me for using the titanium brush, but this is really a big part of the way that I do implant surface decontamination. Titanium brushes are spun at 900 RPM in a latch angle handpiece. And what I like to do is I start from the most apical aspect of the exposed implant and work my way up coronally in a mesiodistal circumferential fashion. The reason for that is because I don't want to potentially drive titanium microparticles down into the bone, because I do follow the literature, and there is some evidence to suggest that these titanium microparticles can create a foreign body response, activate osteoclast, and perpetuate the bone loss process. Following titanium brush application, I'll do a 30-second continuous irrigation with peroxide solution 3%. After titanium brush application, you can see how nice and clean the implant surface looks. And in this particular case, I use xenograft to graft the defect, because at the time that I did this case, I was heavily influenced by the Europeans and the way that they bone graft, and they can only use xenograft in most of the countries there. And I mixed it with some minocycline, commercially known as Arrestin. I grafted the area. Next comes out the membrane. And what's unique about BioExclude, besides all the biological features, is that it's very nicely branded with this smiley face. You can't help but feel happy when you use this particular membrane. And as we've seen from all the presenters today, it's a very easy membrane to manipulate in the site. You don't have to trim it. You can fold it over itself. It's like biologic saran wrap. It just goes right over the bone graft, seals it off, okay? Now this begs the question, what are we looking for in a barrier membrane? So Todd Scantlebury in '92 wrote this article, this summary, I suppose, where he identified various features, and they still hold up to this day. So we want something that's biocompatible. We want something that's not rejected or causing a huge inflammatory response. We want the property of cell exclusion. We want to exclude epithelial cells and gingival connective tissue cells. But over the last 15, 20 years or so, we also recognize that not only do we want cell exclusion, we want nutrient inclusion from the surrounding areas. It's very, very important. Obviously, the BioExclude, as you've seen, is not a space-making or form-stable membrane, but it can certainly help to maintain the space that's created from the bone graft that's underneath it. Clinical manageability and handling is very important. If we asked this whole room their opinions on various membranes, we'd probably get 100 different answers. What works in my hands may not work in yours, and vice versa. Complication tolerance is very, very important. What are the major complications following any bone grafting? The risk of mucosal dehiscence, the wound opening up, leading to membrane exposure. And the problem with this is that this can significantly affect your regenerative outcomes downstream. So in fact, the meta-analysis by Homle Wang's group showed that the collective weighted complication rate is about 18 to 20% for membrane exposure, dehiscences, and infections or abscesses. This leads to 75, 76% decrease in total bone gain. So exposure is generally not a good thing. But what's not on the list of Scantlebury is bioactivity. So wouldn't it be nice if we have all these 5 things on top, but the membrane itself was an active participant in the healing and regeneration process? And so this is where BioExclude comes in. I think there's enough newer people in this room that haven't heard my previous 3 presenters. BioExclude is derived from human placenta. It is an allograft material. It is composed of dehydrated, human deepithelialized, Amnion-Chorion membrane. And it is unique because it has barrier activity, but it's also a carrier in that we have over 250 different biological factors, everything from anti-inflammatory molecules, various cytokines, chemokines, extracellular matrix molecules that all go into this besides just the type 1 and type 3 collagen, which gives the property of bioactivity. It has 2 sides, an amnion side and a chorion side. It is side agnostic. There's no orientation of what side goes up and what side goes down. The only difference is that the amnion is a little bit thinner than the chorion layer, about 4 to 5 times. So the concentration of the various growth factors and molecules is just increased in the chorion part of the membrane. Now, this is derived from human placental material. And placentas typically are not rejected by the body. They're immunoprivileged. And this is why this particular material doesn't elicit a strong, if any, inflammatory response. And last but not least, as we've heard from the other speakers, it has the unique properties of being antimicrobial. So just to recap the different biological features of the Amnion-Chorion membrane, it suppresses inflammation, it's immunoprivileged, it decreases matrix metalloproteinase activity, takes care of all the collagenases and whatnot. It also upregulates the production of tissue inhibitors of metalloproteinases, stimulates angiogenesis. It contains inherently angiogenic growth factor. It stimulates the production of endogenous angiogenic growth factor and also stimulates endothelial cell proliferation. It can also recruit progenitor cells to the area to aid in the healing process, and also facilitates proliferation and migration of cells. And as we've seen some lovely examples from Fatty, Brad, and Matt of how this material can actually enhance keratinization over it. So a lot of biological activity and goodness from this one material. So this to me really represented a paradigm shift. I think about this material very differently than I think about the conventional collagen membrane. It is not just a membrane, but it is also considered a biologic, and I think that in the regulatory process, it's not treated the same way that the other collagen membranes and so forth are. Okay? And this really has shifted my entire view of regenerative therapy, both in terms of around natural teeth, GPR, treating peri-implantitis. So back to Lloyd, we've got our bio-exclude membrane on top of the bone graft. We get primary closure. And then at 1 year, we can see nice healthy tissue here. Probing depths were maybe 4, 5 millimeters with no bleeding. And I want you to make note of the fact that we have this exposed machined collar of the implant. Okay? Look what happens at 2 years. We've got creep up, and we're almost completely covered of that surface. So a lot of people talk about the short-term healing benefits of bio-exclude, and there certainly are, and I'll show you some more of that. But one thing that I want to impress upon you is that the healing process with bio-exclude also continues over the long term. Okay? This is not altered. This is creeping gingiva, coronal migration of the gingival margin to cover up that area of machined collar. I've never seen this happen with any other membrane. Radiographically, if we look at the progression from preoperative to 1 year to 2 years, we can see consolidation of the graft at 1 year and further consolidation at 2 years. Now you're looking at this saying, well, this is just a two-dimensional image, right? Do you have more? There is more. We took CBCTs at 1 year, and you can see the buccal contour that we've created in both of these views. Presumably, all this area here was denuded of bone. Okay, now someone's going to ask me the question, well, how do you know that reosseointegration occurs? We don't know if reosseointegration occurs. We don't. But we know clinically that this area was stable. And radiographically, we see the sustained consolidation of the graft. At 2 years, we see further consolidation of the graft. And look at that contour. Okay? This patient's doing well and comes in regularly for follow-ups. I know it's only 2 years. And we're in that 1 to 5 year period. But so far, so good. And this was one of the first cases that was published on somewhat long-term results with Amnion-Chorion. I had the honor of writing this paper with my two mentors, Dr. Mike Goldberg and Howie Tenenbaum, in JPRD 2022. And if you have nothing better to do with your time tonight, then you can scan that QR code and read the article for yourself. I'll give you a couple of seconds. All right, here's Glenn. Glenn was referred to me for treatment of his 4-6 or number 30 implant, or rather his peri-implantitis. This implant was in function for about 14 years before he was sent to see me. Clinically, we can see that there's suppuration expressed from the gingival crevice. And radiographically, there's something funky going on the mesial aspect. It's either cement, it's either sequestrum, or it's encapsulated xenograft particles, because I believe that Glenn had a socket preservation graft done with xenograft material by the originally treating surgeon. And just like Lloyd before Glenn, he'd had recurrent flare-ups over a 6-month period before he was sent to see me. So again, we put him through non-surgical therapy a couple of times, but then decided that we needed to open things up and see what was going on. So open up we did, and we have a nice contained defect here. There's a couple of walls. There's about 40% dehiscence on the buccal aspect. So we classified this as a class 1B, grade M defect. And you might be wondering what came out of that area. And this is what came out. It looks like a chicken's foot, but it's, I believe it's sequestered xenograft material. One of my colleagues, Dr. Jonathan Doe out in California, has talked about a condition called peri-graftitis. Sometimes we see this, particularly with xenografted areas. So this is good because it actually gives me something tangible to take out, and now I know that this is a very well-contained defect. I have access to clean the implant. In both cases I've shown you so far, I haven't taken off the crown, and you might ask me, why didn't I take off the crown? Two reasons. Number one, they're both cemented crowns, so taking it off would mean sacrificing the crown. It's not an expense that the patient wanted to necessarily get into. Secondly, accessibility was very, very good, so that when I opened my flap, I had access to clean everything properly. And in well-contained defect situations, I don't believe that you necessarily need to remove the crown. So now, next thing is we use our titanium brush. And again, we start at the apical portion, go back and forth, going up coronally until we have a nice clean surface. And I like this picture because what it shows is you have the blood clot in between the threads of the implant, which you don't where it was previously diseased. What I've started doing over the last number of years, influenced by my colleagues, is I take some tetracycline slurry, apply it to the implant surface, because that gives me an added layer of anti-infectivity. And tetracyclines also have the benefit of having anti-collagenylytic activity. So that's very good for a healing wound. I'll also take some of this tetracycline and mix it in with my bone graft. In this case, I've used particulate allograft, which is typically my standard go-to. Grafted the area, placed the bioexclude membrane, and again, it's so thin that you can barely see it in the photograph. But remember, this material comes from placental tissue. If it's good enough to protect the developing fetus, surely it's good enough to protect my developing bone graft. Okay? And don't let the appearance of it fool you. It is flimsy, it looks like brittle plastic, but it is very resilient material. Okay? And of course, we got closure. And radiographically, I've effectively treated this patient's peri-implantitis. We can go home now. No, I'm joking. This is my favorite radiograph. It's always the immediate postoperative radiograph. It's the most successful radiograph that you'll ever see. But in reality, we have to follow the patient up. And so his healing was very uneventful. At 3 months, I was a bit concerned when I saw this appearance. The marginal tissues appear to be healthy. There's no pus or suppuration or anything like that, but this doesn't look that good. And everyone's like telling me that bioexclude is amazing for short-term healing. Just give it time, give it patience, maintain good oral hygiene. At 6 months, we can see that this area is starting to close up. At 9 months or 1 year, we can see that there's further improvement in this area. Radiographically, we can see good consolidation of the bone graft. And at 2 years, we see further improvement of that soft tissue area interproximally. And at 3 years, we see even continued. So again, it's not just a short-term healing of the bioexclude. I think that the effect of it carries on for the long term. You just have to have the patience to see that through. Radiographically, we can see sustained bone levels over at least that 3-year period. And clinically, there's no issue. So the last case I'm going to show you is a case of Deborah. Deborah is a very high-function ICU nurse, very medically, dentally aware, high IQ. She'd practically start her own IV if I told her it was okay. Obviously, we can see this soft tissue dehiscence accompanied by this 30-35% bone loss. So there's 2 problems in one here that I have to treat. Again, put this patient through non-surgical therapy, get them ready for surgery. So what's my approach going to be here? Am I going to do a soft tissue graft first? Am I going to raise a flap, do a regenerative procedure? I opted for doing a flapped regenerative procedure. So when we elevated our flap, this is what we saw. We saw this wide diameter, we call them the fat boy implants that were used for immediate molar sites. But we see that it's integrated, it's well contained, and I really don't want the onerous task of having to explant this big implant. It's about a 6 millimeter, 7 millimeter defect, but again, it's well contained and I have good access. Classified as a 1B grade M defect for the reasons I mentioned earlier. We start with our titanium brush treatment, 30-second irrigation of 3% peroxide solution, and we can see that we've got this nice clean implant surface. Apply tetracycline to the implant surface, And this is a clinical reality. I got a bit overzealous with my bone graft here. I didn't realize that you needed just a little bit of tetracycline in the bone graft, so I just sprayed it all over. Nonetheless, that's the bone graft for you, and BioExclude on top with the membrane folded over. Okay, and again, you don't need to cut this membrane. Why get rid of the biological activity that's in the membrane? Now you'll notice that the closure here is incomplete. For whatever reason, I just wasn't able, even with my tremendous surgical skills, to advance this flap coronally to cover that membrane. Now, this begs the question, are you worried about leaving the BioExclude exposed? And my answer to that question is no, I'm not. Because my first foray into using BioExclude was just like with Dr. Fine, over sockets. So here's a typical case of a socket preservation, atraumatic extraction of tooth number 19, xenograft grafting of the socket, BioExclude placed over the top, and a diagonal continuous suture. And I want you to note how much of the membrane is left exposed. Now I'm going to show you the result at 10 days postoperatively. Okay? And let's look at that a little closer. No other membrane or barrier is going to give you closure like that over your wound with the keratinization. Okay? So part one to the answer of can I leave it exposed? Yes. Now what's the other concern about leaving membrane exposed? Bacterial contamination. So luckily, we have a couple of really nice studies that have looked at bacterial contamination and the possibility of it with Amnion-Chorion membranes. The first study by Ashraf and coworkers, they had 4 experimental groups. They had 4 discs. They coated one with just paper, one with a collagen membrane, it was BioGuide, one with tetracycline, and one with Amnion-Chorion membrane. And what they found was that the kill rate of the bacteria, which was a virulent periodontal pathogen, AA, was virtually identical between Amnion-Chorion membranes and the tetracycline-coated plates. You can see that the bacteria actually proliferated in the presence of the native type 1 collagen membrane. Another study pitted Amnion-Chorion against a pericardium collagen membrane, and they looked at the colonization of S. gordoni, which is an early biofilm colonizer. Green means life, and red means death. You can see that at 24 hours, the colonization on the collagen membrane is through the roof. But everything on the Amnion-Chorion membrane, there's maybe only 1 or 2 green lights that I see on that. Okay? So yes, I can leave the membrane exposed. At 1 year, we take a radiograph and we can see good bone fill. You can't even tell where the graft was done. It's turned over very, very nicely. But I want you to see the clinical picture. Okay? Do you see that dehiscence anymore? No. And why don't we see that dehiscence? I'll tell you why we don't see that dehiscence. It's because the exposed basement membrane of the Amnion-Chorion contains a molecule called laminin, which is the extracellular matrix molecule that facilitates migration of epithelial cells and keratinocytes. So you can leave this exposed. What about at 2 years? We see continued soft tissue maturation over that implant dehiscence and further consolidation of the bone graft. And at 3 years, we see even further sustained soft tissue over that implant surface and nice stable bone levels. This is where we started. This is where we are, and we've regenerated essentially 2 millimeters of new keratinized gingiva. And radiographically, this is where we were, and this is where we are today. Unfortunately, this patient comes annually to see me around this time. I tried to get her in last week for her 4-year follow-up, but she just couldn't make it, so maybe in a subsequent presentation. So my surgical treatment power play for peri-implantitis is as follows. After accurate diagnosis, classification of the defect, we do a thorough debridement degranulation, titanium brush decontamination of the implant surface, followed by peroxide irrigation for 30 seconds. I like to put tetracycline on the surface of the implant and into the bone graft as well, and then use BioExclude to cover up that bone graft. Now, all this is great when you're doing the surgery, but it all falls apart if you don't have long-term follow-up and maintenance. That is really one of the important keys in maintaining the stability of the long-term result. Okay? So, some final thoughts. I think we're almost at the end. I think I've been able to show you, even just in these handful of cases, but I can show you many, many more if time allowed, that regeneration of bone in areas that were previously affected by peri-implant disease can be treated successfully and predictably. But really, the two important factors are our access to debride, our ability to decontaminate the implant surface, and also the defect debridement and configuration, okay? Because not all defects are amenable necessarily to regenerative therapy. And I think given the unique biological properties of BioExclude, it should be part of every surgical peri-implantitis treatment case. Whether you use it the way that I did or whether you use it as Dr. Fine has shown by cutting up into little pieces and putting it as part of your bone graft. Just the antimicrobial activity, the growth factors alone make this very, very unique material. And of course, as I mentioned just a slide ago, strict follow-up and long-term maintenance is the key. Because we don't know, these things could fall apart at any minute. But so far, so good. With that being said, thank you all. This has really been a pleasure for me. Thank you, Matt, for the invitation to speak. You can email me anytime. Here's my link to social media. Have a great rest of your AAP and enjoy the city. Thank you very much. Questions?
Has anybody ever tried BioExclude directly on a decontaminated implant?
Great question. I was actually thinking about that a couple of weeks ago. Like after we decontaminate the implant surface, put a layer of BioExclude on top of it, and then graft over top. I think it's a great idea. Why not? It's worth a try. It's off-label, but it's worth a try.
So, and then for conservative therapy, so for maintenance subsequently, do you recommend or have you seen evidence that using iodine in the syringe, like a subgingival irrigation, or peroxide, would that be of any benefit, or is that contaminating your surface?
No, I've seen evidence to support iodine as well. I mean, you don't have to do iodine and peroxide. I think one or the other would be fine. Yeah. Question?
Talk about the post-op care.
Absolutely. So post-op care, I typically put my patients on 1 week of antibiotics, systemic antibiotics, a pain reliever like Toradol or Ketorolac, and warm salt water rinses or warm plain water rinses 3 to 4 times a day. I do not use chlorhexidine. Just because of some of the evidence suggesting that it could be cytotoxic. I just also don't like the fact that it stains the implant crowns and the teeth and whatnot. So very simple, super gingival oral hygiene in the area, no brushing, no flossing for about a week, and that's about it. Yeah. Thank you. Joshua.